You went to the doctor, you got blood work done, and the doctor's office called and said, everything looks normal. And you sit there thinking, then why do I feel like this? Why am I so exhausted? And why can't I even lose a pound? Why do I crash every afternoon around 3 o'clock? Why don't I feel normal? And maybe you asked your doctor these questions, and maybe the answer was, well, sometimes people just feel this way. Or maybe try eating better, or exercising more, or maybe it's just stress. And you left the doctor's office with no answers and a quiet, unsettling feeling that something is being missed. And you know, something is being missed. And today I'm going to show you exactly what it is, why standard labs keep missing it, and what lab tests need to be ordered instead. Hi, I'm Dr. Kim, the insulin resistance doctor. And my mission is to help you recognize the symptoms, understand your lab work, and know exactly what to do next so you can change your future before type 2 diabetes does. This video today covers question 7 of my free 1-minute insulin resistance risk assessment. My doctor has told me my blood sugar is normal, but I still don't feel right. If that's your story, go take the full assessment. The link is in the description below this video. There are 10 questions that take about 1 minute to answer. And if you send me an email, I will personally respond to it. And again, the email link is in the description. You know, this is one of the most common experiences people bring to me in clinical practice, that they have normal blood sugar and no fasting insulin test to complete the picture. And it represents a fundamental gap between what standard medicine is designed to find and what a functional medicine doctor like me looks for. Standard medicine is looking for diseases. It uses reference ranges that are designed to identify pathology, numbers that have crossed into diagnosable territory. When your labs fall within those ranges, the system says you're normal, go home. But functional medicine asks an entirely different question. And I ask, is your system functioning optimally? Optimal function and the absence of disease are not the same things. And there is a lot of space between thriving and diagnosable. And that's exactly where insulin resistance lives, in the space between thriving and diagnosable for years, sometimes decades, before standards labs catch it. And I had to find it out in my 60s. And I want to be careful here because I'm not saying your doctor was wrong or didn't care. Standard reference ranges exist for a reason, and they serve important purposes. But what I am saying is that standard reference ranges were designed to identify disease and not to catch early dysfunction. Here's how standard blood glucose reference ranges work. The normal range for fasting blood glucose in most labs is 70 to 99 milligrams per deciliter. A lab value of 100 to 125 is considered prediabetes, and above 126 milligram per deciliter is considered type 2 diabetes. So if your fasting glucose is 94, you're considered normal. The lab didn't even flag it, and you think it's normal. And the doctor says, you know, it's normal. And it is normal by that definition, but here's what 94 milligrams per deciliter doesn't tell you. It doesn't tell you how much insulin your pancreas had to produce to keep blood sugar at 94. It doesn't tell you whether your cells are responding well to insulin or whether your pancreas is working 3 times as hard as it should to maintain that number of 94. A fasting glucose of 94 achieved by a pancreas producing normal amounts of insulin is a completely different metabolic situation than a fasting glucose of 94 achieved by a pancreas in overdrive, flooding your system with insulin just to keep blood sugar from rising. The glucose number looks identical, but the underlying metabolic reality is entirely different. And without a fasting insulin blood level, you cannot tell the difference. In functional medicine, we check function, and the test that is almost never ordered on a standard panel that tests function that would catch this is a fasting insulin blood level. Fasting insulin measures how much insulin your pancreas is producing in a fasted state. In a healthy, insulin-sensitive person, fasting insulin is low, ideally under 5 or 6 microunits per milliliter, though most conventional labs call anything under 25 normal. That conventional normal range under 25 is one of the most misleading ranges in standard medicine, because a fasting insulin of 20, 18 or 20, while technically within the conventional normal range, represents significant insulin resistance. The pancreas is producing 4 to 5 times more insulin than an optimally functioning system would need to keep blood sugar at the same level. That person with a fasting glucose of 94 and a fasting insulin of 18 or 20 will have a HOMA-IR well above 4, and they will have significant symptoms, and they will feel the effects of chronically elevated insulin, and they will be told their labs are normal. This is not a failure of the doctor's character. It is a failure of the screening tool. Fasting insulin is not on a standard metabolic panel. It has to be specifically asked for and specifically ordered. And most physicians trained in disease management, in the disease management model, don't have a clinical trigger to order it in someone whose blood sugar looks fine. That's the gap. Now let me walk you through the difference between conventional and functional reference ranges for key markers, because this will reframe what normal means entirely. Now don't just listen, go grab a pen and paper, and I want you to write these numbers down, or stop the video and write them down. And the next time your doctor says labs are normal, you'll know exactly what to look for. And I do this all the time. I write my own numbers down and I talk to my doctor. This could change the way you look at your lab results forever. Fasting glucose. The conventional normal range is 70 to 99 milligrams per deciliter, and functional optimal is 70 to 85 milligrams per deciliter. The upper range of 85 to 99 is still called normal conventionally, and is a range where functional medicine starts asking questions, especially when combined with fasting insulin. Fasting insulin. Now, the conventional normal is typically 2 to 25 microunits per milliliter, depending on the lab. Now, the functional optimal is under 5, ideally under 8, and mine was 6.1 at my last doctor visit a couple weeks ago. A reading of 15 or 20 is flagged as normal by most conventional labs, but is a clear signal of compensatory hyperinsulinemia. Go look that term up in functional medicine. HOMA-IR. Now, HOMA-IR is not on a standard lab panel at all and has to be calculated. The calculation is take your fasting blood glucose level and add your fasting blood insulin level together, then divide the total by 405, and this equals the ratio. Now, the functional optimal is 1.0, and mine was recently 1.5. Under 2.0 is acceptable, but above 2.0 is in the presence of symptoms is meaningful, and above 3.0 is significant. This number simply doesn't exist in most people's medical records, and because nobody has calculated it, you will need to calculate it yourself. Triglycerides. Now, conventional normal is under 150. Functional optimal is under 100, and ideally under 80, and mine was 59 the last time I was checked. Triglycerides above 100 in the presence of other symptoms is a useful early signal of insulin resistance, even when flagged as conventionally normal. None of these are catching you in a technicality. They're all about asking whether the system is functioning well, not just whether it has crossed a disease threshold. And I want to speak directly to the experience of being told you're normal when you don't feel normal, because this is a cost beyond the physical symptoms. It creates self-doubt. People start to wonder if it's all in their head, if they're being too sensitive, or if they should just push through. Now, I've had patients who spent years being told their labs were fine, attributing their symptoms to stress or age or personality, before finally finding out that insulin resistance was present and measurable the entire time. And when they finally understand what was actually happening, when they see their fasting insulin in their HOMA IR, and the picture becomes clear, the most common response I hear is not anger at all, it's relief. Relief that they weren't imagining it, that they weren't imagining the symptoms, that there was really something happening behind the scenes, that it has a name and a mechanism and a path forward, and that you're not imagining it. The tool being used to evaluate you was not looking in the right place, and that's not your fault. And it's not a reason to stop looking, especially if you've been told your labs are normal and you still don't feel right. Take the full risk assessment in the description below. Your symptom total tells me a lot about how complete the picture of insulin resistance really is for you, even before any labs are run. So now, what do I suggest that you do? First, know what tests to ask for specifically. At your next blood draw, ask your doctor for a fasting insulin and a fasting glucose level. Ask for both at the same blood draw so you can calculate your own HOMA IR yourself, because it will not be done for you. And also ask for a hemoglobin A1C and a full lipid panel, including triglycerides. Write these down before your appointment. And second, know the functional optimal ranges. Fasting insulin under 8, fasting glucose under 85, HOMA IR under 1.5, triglycerides over 100, hemoglobin A1C ideally 1.5 or below. And we did not touch on this value in the video, but we will in a future video. And if your results fall between conventional normal and functional optimal, that is useful clinical information, not reassurance to ignore. Third, bring your symptoms to the conversation, not just your labs. Fatigue, afternoon cravings, weight that won't budge, disrupted sleep, growing waistline. These are symptoms, and they belong in the clinical conversation along the numbers. If a doctor dismisses them because your labs look normal, you have not found the right answer or the right doctor. Fourth, take the risk assessment in the description below. Provide your email, and the assessment is immediately available to you. A standard blood panel is a starting point. It's not the full picture. And for millions of people with insulin resistance, 88% of us, it is not even close to the right picture, because it was never designed to catch what they have. You deserve a complete picture. You deserve labs that ask the right questions, and you deserve a practitioner who listens to your symptoms as data, not as anxiety. So now go take the risk assessment and email me your score. Tell me your biggest struggle. I read every response personally, and I'll send you back exactly what I'd want to look for in your situation. Thank you for watching this video. I'm Dr. Kim, the insulin resistance doctor. I want you to know your numbers so you can change your future. Over the past several weeks, we've walked through the major signs and clues that can point towards insulin resistance. If you've been following this series, you now have a better understanding of what to look for. But recognizing the clues is only the beginning. In my next video, we're going to take the next step together. I'll show you how to understand your blood work, how to connect your symptoms, and most importantly, what you can do to improve your metabolic health going forward. So if you haven't already subscribed, please do, because we are just getting started. Thank you.